Imagine you're sitting in the clinic and you are staring at a patient's severely bruised skin. And you know that the very next prescription you write will either, cure their absolute agony or it's going to cause their tissue to just physically collapse.
Yeah, it's a terrifying scenario to be in, honestly.
Right. Welcome to today's deep dive. If you're a clinician or just, studying up on complex dermatology, you know that medicine isn't always this clean binary equation. Sometimes it's a medical mimic.
Oh, absolutely. And misinterpreting the physical evidence in those cases doesn't just delay healing. You might actually be pouring gasoline on the fire.
Exactly. So our mission for today's deep dive, and we are pulling from a massive stack of dermatology manuals, clinical studies, dermoscopy journals. Our mission is to solve this incredibly high-stakes puzzle. What happens when the gold standard treatment for a severe skin condition starts to, perfectly mimic the exact symptoms of the disease itself?
It really is one of the most perilous diagnostic traps out there.
It is. We need to map out how you clinically differentiate between two visually identical emergencies. On one side, you have the bleeding and bruising purpura, right, caused by an active flare-up of a chronic disease called lichen sclerosus.
Right, active LS.
And on the other side, you've got the exact same bleeding and bruising. But in this case, the ecchymosis is actually caused by the long-term use of the ultra-potent topical steroids that you prescribed to treat the LS.
It's a huge paradox.
To ground this for you listening, it's basically like looking at a crumbling house and trying to figure out if the structural damage is from the termites or if it's from the harsh chemicals you've been spraying to get rid of the termites.
That is honestly a perfect way to look at it, because getting this wrong, it has massive implications for the patient's quality of life. You're talking about accelerating tissue destruction if you make the wrong call.
So to even begin untangling this, we really need to understand the baseline, right? We need to look at what lichen sclerosus, or LS, is actually doing to the body's architecture when it's just raging out of control.
Right, we have to start with the disease itself.
So reading through the sources, they keep describing this classic LS presentation where the skin turns this porcelain-white color and thins out. And my immediate thought is, okay, the blood supply is getting choked off. Is that what's happening? Or is the immune system doing something else?
Well, you're definitely picking up on the key visual with that porcelain white color. But the actual mechanism is driven by chronic inflammation.
Okay.
Yeah, lichen sclerosus is an inflammatory autoimmune skin disorder. And, while it can pop up anywhere on the body, it has a really strong predilection for the anogenital area.
Right, the sources mentioned a very specific pattern there.
Exactly. The immune system is basically launching a localized attack right at the basement membrane of the skin. And clinically, this creates this distinct, the literature calls it a figure of 8, or a keyhole configuration.
A keyhole shape.
Yeah, encompassing the vulvar and perianal regions.
Mm-hmm. And that autoimmune attack, that's what changes the actual texture of the skin too, right? Because the clinical texts use this phrase, cigarette paper, to describe the skin.
Yes, the cigarette paper appearance. The skin becomes highly atrophic.
Which means it's losing its normal thickness.
Right. It loses its thickness and its resilience. It takes on this ivory, wrinkled, just an incredibly fragile appearance.
Yeah.
But honestly, the defining symptom, the thing that really drives patients to the absolute brink, is the itch.
The pruritus.
The pruritus, yeah. And we are not talking about, the mild annoyance of a mosquito bite here.
Right.
The itching in active LS can be so severe that it literally wakes patients out of a dead sleep. It completely dictates their entire quality of life.
Wow.
And that severe itch, that is the direct driver of the first half of our diagnostic puzzle, the purpura.
Which, okay, that actually brings up a massive contradiction that I found in the source material, or, well, it seems like a contradiction at first glance.
Which part?
So if you look at active LS under a dermoscope, and for you listening, that's a specialized magnifying tool doctors use to look deep into the skin layers, the texts explicitly state that the blood vessels in LS are markedly decreased.
Yes, they are.
So if there are barely any functional blood vessels left in this, porcelain-white, thinned-out tissue, how in the world is a patient developing massive red and purple bruising? How do you get a bleed without a blood supply?
I know, it seems completely paradoxical, doesn't it?
Totally backward.
But it comes down to understanding the mechanical reality of what the patient is actually experiencing. The purpura in active LS, it isn't spontaneous.
Oh, it's not?
No, it's a trauma response. Think about it. You have a patient dealing with this unbearable systemic itch, right? And their only recourse is to scratch.
Oh, so they are physically causing the bleed.
Exactly, because the tissue is already highly inflamed, atrophic, and just incredibly weak from the autoimmune process. That uncontrollable repeated scratching leads to severe mechanical tearing.
Man, so they're essentially shredding whatever microvasculature is actually left in that area.
Yes, the tissue has zero resilience. So even a drastically decreased number of vessels, they'll just rupture under the sheer force of the patient desperately trying to relieve the itch.
That sounds agonizing.
It really is. The scratching produces erosions, deep fissures, and ultimately that purpuric bleeding that just pools right under the skin.
Okay, so if you're a clinician and you're looking through a dermoscope right now, trying to verify that this is active LS, you might expect to just see, I don't know, a wash of red from all that pooled blood. But the sources highlight a really specific visual fingerprint for the active disease, right?
They do, yeah. When you look through the dermoscope, you're going to see a whitish background, which makes sense. It correlates to that porcelain clinical appearance.
Right, the white skin.
And you'll also spot these comedo-like openings, which are basically just plugged hair follicles.
Mhm.
But the most distinct feature, alongside the lack of prominent vessels, is what dermatologists call peppering.
Peppering, like actual black pepper scattered across the lens.
Visually, yeah, pretty much. They
Mhm.
appear as these tiny blue-gray dots just scattered all through the tissue.
What are they?
They're melanophages.
Oh,
So during that really intense inflammatory process of the immune attack, pigment actually drops down into the deeper layers of the dermis.
okay.
And the immune system sends in these macrophages to swallow up the loose pigment. And then they just kind of sit there.
Wow, they just get smuck.
Yep. So when you see that blue-gray peppering through the scope, you are essentially looking at the fossilized remains of chronic inflammation.
The fossilized ghosts of inflammation. That's fascinating. Okay, so that establishes our baseline.
Right.
We have an active autoimmune disease. The skin is white, it's thin, it's peppered with these blue-gray melanophages. The vessels are sparse, but that intractable itch leads to violent mechanical scratching, which then causes the severe purpura.
You've got a perfect...
So naturally, if the root cause of this brutal trauma is the inflammation that's driving the itch, shutting down, that inflammation should solve the problem entirely, right?
And it does. The gold standard treatment for lichen sclerosis, and this is across all clinical guidelines, is the application of ultra-potent topical corticosteroids.
Okay.
They are just remarkably effective at halting that immune cascade, suppressing the inflammation, and stopping the disease from progressing.
But, and this is where our deep dive really gets complicated, what happens when the cure overstays its welcome?
Right, the double-edged sword.
Because applying ultra-strong steroids to, the most sensitive, delicate skin on the human body for months or sometimes even years, that introduces a completely new pathology.
It absolutely does. And to understand why the treatment and look closely at the cellular biology of steroid-induced atrophy.
Let's do it. Let's unpack that.
So when you apply a highly potent topical corticosteroid for a prolonged period, you aren't just dealing with surface-level changes. You are fundamentally altering the microscopic architecture of the dermis.
What are the steroids actively doing to the tissue over that long term?
Basically, they drastically reduce dermal volume by attacking the support structures. So first, the steroids inhibit the activity of fibroblasts.
Fibroblasts, those are
They're the primary factory workers of your skin. They are the cells responsible for producing collagen and elastic fibers.
Okay, so if you shut down the fibroblasts, you're literally stopping the production of the skin's structural scaffolding.
Exactly. You are turning off the factory.
Wait, so the steroids aren't just, temporarily thinning the surface layer. They are actively shutting down the body's ability to rebuild its own deeper structural support.
Yeah, they really are. And it gets worse because the sources also mention that steroids deplete glycosaminoglycans.
That's a mouthful.
Mhm.
Are those related to the scaffolding too?
They are integral to it. Glycosaminoglycans, they're these large molecules that bind and hold water within the skin. They are what keep healthy tissue plump, cushioned and hydrated.
Oh, I see.
So the steroids are halting the production of new collagen, and simultaneously they're evaporating the hydration network.
Okay, I have an analogy for this. Tell me if this works.
Let's hear it.
Think of a healthy dermis, like a water balloon, right? But it's filled with a really thick protective gel. And running right through the middle of that gel is a fragile glass tube, which represents the blood vessel.
Okay, I'm following.
If you tap on the outside of that balloon, the thick gel absorbs all the shock. The glass tube inside is perfectly safe.
That is actually an excellent way to visualize the mechanics. The collagen and the glycosaminoglycans, they are that thick, shock-absorbing gel.
Right. But long-term, ultra-potent steroids basically evaporate that gel. They dissolve the collagen and they drain the water-binding molecules. So now what you're left with is just a thin, flimsy rubber balloon resting directly against that fragile glass tube.
Yes. Which means the blood vessels are practically floating naked right beneath a severely thinned out epidermis.
Wow.
Without that fibrous, gel-like support matrix, they have absolutely zero cushioning left.
And this explains the ecchymosis, the bleeding caused by the treatment itself.
Exactly.
Because that protective gel is gone, you don't even need the violent, frantic scratching of an LS flare-up to break the glass tube anymore.
You really don't.
Yeah.
The threshold for trauma just completely plummets. We are talking of the light incidental friction of daily life.
Like what? Just walking?
Literally just walking.
Yeah.
The simple act of walking, the friction of wiping after using the restroom, the rubbing of your underwear, or honestly, merely sitting down in a chair.
Just sitting down.
Yeah, that minimal, unavoidable friction is enough to shear those naked blood vessels against the thin epidermis, and that leads to extensive dermal ecchymosis.
Man, the paradox is just brutal. I mean, the disease causes bruising because the inflammation makes you scratch so hard you rip your own skin apart. But the treatment causes bruising because it dissolves your cellular scaffolding to the point where just existing and moving causes your blood vessels to pop.
It's a terrifying catch-22 for the patient.
Yeah.
And if we bring the dermoscope back into the picture now, the visual fingerprint of this steroid damage is the exact opposite of the active disease we discussed earlier.
Right, because active LS had almost no visible blood vessels, and it had that blue-gray peppering. So what does the steroid-damaged skin look like under the polarized light?
You're going to see profound, chaotic, highly visible blood vessels right at the surface.
Oh, really?
Yeah, clinically, this is called telangiectasia. The steroids haven't just thinned the skin. The loss of the structural matrix actually causes the vessels to become heavily dilated and prominent.
You know, the sources mentioned some really specific, almost bizarre shapes for these vessels under the dermoscope. They describe them as polygonal webs, Y-shaped bifurcations, and these serpentine snake-like lines. Why don't they just look like normal, straight blood vessels?
Because the physical scaffolding is completely gone. The vessels aren't held in their normal, neat anatomical shape anymore, so they just sprawl out and distort right under the surface.
Oh, it's like vines that have completely lost their trellis.
That's exactly it.
They just collapse onto the ground and grow into these chaotic serpentine shapes because there's literally nothing left to hold them in place.
That is exactly what you're seeing through the lens. You're looking at a massive, disorganized vascular network floating without a trellis, just waiting for the absolute slightest friction to burst.
That's wild.
And alongside those sprawling vessels, you'll also see broad, diffuse red areas and highly prominent underlying veins.
Just because the skin is so thin?
Exactly. The tissue has become virtually transparent.
Okay, this brings us to the ultimate clinical showdown. Let's put you, the listener, right in the diagnostic seat.
A hot seat.
Yeah. A patient walks into your clinic. They have white, wrinkled skin in the anogenital region, and it is covered in severe purple and red bruising. How do you know if the lichen sclerosis is flaring up and desperately needs a steroid application, or if the steroids have already hollowed out the skin and need to be stopped immediately?
This is the crux of modern dermatological care for this condition. And thankfully, the literature provides clinicians with 3 vital diagnostic keys to differentiate the two.
Okay, let's go through them. Key number 1.
The first key relies entirely on taking a careful, detailed patient history. You have to understand the behavioral trigger.
The symptom profile. So you're looking for the presence or the distinct absence of the itch.
Precisely. If the patient presents with this bruising and they report a returning intractable pruritus, if they look at you and say, "I am waking up at night scratching again," the clinical scales tip heavily toward active lichen sclerosis.
Because the inflammation is back, which drives the itch, which drives the mechanical trauma.
Right. But if they say, "I haven't felt an itch in 6 months, I'm not scratching at all, but every time I wear tight pants or go for a long walk, I come home covered in dark purple bruises."
That tells a completely different story.
It does. That lack of itch, combined with bruising induced by simple, everyday friction, points a giant neon sign at steroid-induced dermal atrophy. It tells you the glass tube is breaking without any violent force.
That makes incredible sense. You differentiate based on the trigger,
Right.
active scratching versus passive friction.
Exactly.
So what is the second diagnostic key?
The second key involves zooming out. You need to look at the macroarchitectural changes of the patient's anatomy, the physical lasting cues left behind by the disease process versus the side effects of the medication.
I noticed this in the clinical studies. Active unmanaged LS leads to severe anatomical loss. Does the disease literally melt the anatomy away?
It's more of a process of intense scarring and structural resorption. The chronic inflammation of an active LS flare-up, over time, it can cause scarring so severe that it leads to the complete obliteration and flattening of the labia minora.
Wow.
Yeah, and it frequently causes clitoral phimosis, which is when the clitoris becomes entirely buried and trapped under thick scar tissue. It can even cause severe narrowing of the vaginal introitus.
So these are the anatomical hallmarks of the disease process running unchecked. You're looking for heavy scarring and the physical loss of anatomical landmarks.
Right. But the steroid damage presents differently on a macro level.
Very differently, right.
Very. Steroid atrophy does not cause that kind of fibrotic scarring. Instead, the skin becomes extremely lax, almost loose, and incredibly shiny. You'll frequently observe striae, which are stretch marks caused by the loss of elasticity. And that's alongside that transparency we discussed earlier.
So just to recap for you listening, active disease equals heavy scarring, narrowing, and anatomical loss. Steroid damage equals shiny, loose, stretch-marked skin where you can clearly see the veins underneath.
But, and here's where the reality of the clinic hits hard, sometimes a patient has been managing this condition for a decade, right?
Oh, so they might have both.
Exactly. They have a complex mix. They have old LS scarring from years ago, but currently they might be overusing their topical steroid.
That's a nightmare. So when the history is muddy and the anatomy is mixed, you need the ultimate tiebreaker.
The third key, the dermoscope. This is where we look at the microscopic evidence.
Okay, so you place the polarized lens against the bruised skin. Walk us through it.
If the tool reveals red-purple globules and blotches, which are the physical pools of blood from the scratching trauma, alongside a distinct absence of prominent blood vessels, and you see that blue-gray peppering.
Then you are definitively looking at active LS. The trellis is still there, but the pipes are hidden, and there's blood pooled from external trauma.
Yes. But if that lens reveals a chaotic, bright red network of branching, polygonal, and Y-shaped blood vessels, that massive telangiectasia we talked about, you're looking at steroid damage.
The trellis is gone, and the sprawling vines are fully exposed.
Exactly.
Let's talk about the clinical study cited in the Journal of Dermatology, because I think it perfectly crystallizes the stakes of getting this right. What exactly did the researchers do in this study, and what did they see?
Well, they designed a 6-month observational study. They followed a cohort of patients who presented with both active lichen sclerosis and severe widespread purpura.
Right.
And the researchers prescribed the standard regimen of ultra-potent topical corticosteroids, and then they tracked the structural integrity of the patient's skin week by week.
Which, on its face, feels entirely counterintuitive, right? You have patients coming in with massive bleeding and bruising, and the doctors are prescribing a medication known to thin the skin and cause bleeding.
It does sound crazy, but it highlights the necessity of accurate differentiation. Week by week, as the patients applied the steroids, the researchers observed the inflammation subsiding.
Okay.
And as the immune cascade halted, the intractable pruritus vanished.
The itch stopped?
The itch stopped entirely.
Yeah.
And without the itch, the mechanical trauma of violent scratching ceased. Over the 6-month period, the researchers watched the severe purpura completely fade away.
Wow.
Counterintuitively, the skin's barrier function actually improved during this initial phase because the destructive disease process was halted, which allowed the tissue to undergo normal healing.
It totally proves the mechanism. If the massive bruising is truly a symptom of the active disease, applying the skin-thinning steroid will actually fix the bruising because it eliminates the behavioral trigger.
Exactly. Therefore, the clinical takeaway from this study is absolute. If a patient is on long-term topical steroids and the bruising persists, or worse, begins to accelerate despite the inflammation being controlled,
The steroid is no longer the cure.
right, it has crossed the threshold and become the culprit.
You can really see the trap here, right?
Yeah.
If you, the clinician, assume the bruising is just the disease being stubborn, and you tell the patient to increase their steroid use, you are actively destroying whatever dermal barrier they have left.
You're obliterating it.
The vessels become more exposed, the bruising turns catastrophic, and the patient is just left vulnerable to secondary infections and severe chronic pain. It all comes down to understanding the why behind the bleed.
Yes.
Are you looking at mechanical destruction due to a low vessel, highly inflamed, itchy disease? Or are you looking at a structural collapse due to a high vessel, fragile, steroid hollow dermis that's just reacting to the mere friction of existing?
That is the ultimate question. And the ability to answer that question is what separates adequate care from exceptional care.
Absolutely.
And, if we connect this highly specific diagnostic puzzle to the broader landscape of modern medicine, I really think there's a profound takeaway here about how we observe the human body.
Oh.
Well, think about the technology we've been discussing today. A dermoscope is, at its core, basically a highly calibrated magnifying glass equipped with polarized light.
Right.
It doesn't require an incision. It doesn't require a painful tissue biopsy. It's entirely non-invasive. Yet, simply by utilizing light and magnification, a clinician is granted the ability to peer through the epidermis and read the history of the tissue, almost like the rings of a tree.
Wow, like the rings of a tree. That's a great image.
You can literally see the fossilized ghosts of old autoimmune inflammation resting in the deep layers of the skin. And you can visually verify the catastrophic architectural collapse of the dermal matrix by observing how those blood vessels sprawl out chaotically when they lose their support.
It really is amazing what you can see if you just know what to look for.
Exactly. This simple, elegant tool gives us the power to step out of the murky, subjective waters of diagnostic guesswork. It allows us to firmly differentiate between a disease and its cure, preventing well-meaning clinicians from falling into the ultimate medical trap.
Continuing a treatment that has perfectly and dangerously mimicked the very disease it was meant to defeat.
Couldn't have said it better.
Something to mull over the next time you're looking for answers in the clinic. Thanks for joining us on this deep dive.